Hello, I'm Dr. Harold Koenig. I do research on the topic of religion, spirituality, and health at Duke University Medical Center. I'm a physician and take care of patients as well. But the primary thing that I do is I design and conduct studies and evaluate the research of other people who examine this connection between religion, spirituality, and health. So, although I'm a clinician, I'm also really a researcher, and that's what I'm trained in and what I train other people to do. So today I'm going to talk to you about this connection between religion, spirituality, and health, and go over some of the research that's been done to examine how these areas seem to be connected to one another. I'm going to start, first of all, here with an overview. I'm going to define some terms that some of you may or may not be familiar with. I'm going to review some of the early research that was conducted prior to 2010. I'm then going to go over some recent research that we've been doing here at Duke University Medical Center. Finally, I'm going to talk about how do you integrate this information into clinical practice? How do you integrate spirituality into the care of patients? And finally, I'm going to provide you with a list of resources that you can turn to learn a little bit more about this area. First, I'd like to talk a little bit about terms such as religion and spirituality. There's a lot of controversy about what these terms mean, and I'd like to kind of talk a little bit about that. The first term of significance is religion. Now, religion, pretty much everyone agrees on. It involves beliefs, practices, and rituals related to the transcendent, where in Western traditions, the transcendent is also called God, Allah, Hashem, a higher power. In Eastern traditions, the transcendent might be called Vishnu or Krishna, Buddha, or be associated with ultimate truth or reality. Religions usually have doctrines about life after death and rules to guide behavior during the present life. Religion is often organized as a community, but can also exist outside of an institution and may be practiced alone and in private. Religiosity and religious involvement can be measured and quantified and related to health outcomes. Now, the term spirituality, on the other hand, is a little bit more diffuse. According to the traditional definition, spirituality was the core of what it meant to be religious. In other words, describing those who were deeply religious, living a life dedicated and surrendered to the divine. The modern definition of spirituality, however, has become much broader, including not only those who are deeply religious, but those who are superficially religious and those who are not religious at all. In other words, secular humanists. Given the lack of a universal definition and largely the self-defined nature of spirituality, it's really too vague and nebulous of a concept to be useful when conducting quantitative research. This is in particular when we're trying to measure a person's religion/spirituality and we're trying to correlate it with health outcomes. Spirituality is just too diffuse a concept to be able to really measure and quantify. But religion is a little different. We can measure a person's religiosity. We can measure their religious practices, and we can correlate that with health outcomes. And that's what I'm going to describe for you now. So let's talk a little bit about the past research. I'm going to talk about religion and coping with illness, religion, mental and social health, religion and health behaviors, and religion and physical health. So I'm talking a lot here about religion, not so much about spirituality. And that's because the research that's been done, that is valid research, really has been looking at religion, religious beliefs and practices. The research that looks at spirituality often uses measures that are confounded with the outcome, with the mental health or social health or physical health outcome. So those studies are much less credible than our studies that are measuring religious beliefs and activities that everyone can agree on and are clearly defined and that we can measure and quantify. So first of all, with regard to religion as a coping behavior, many people turn to religion for comfort when they are stressed. Religion is often used to cope with common problems in life, especially those involving medical or psychiatric illness. Religion is often used to cope with challenges such as uncertainty, fear, pain, disability, loss of control, discouragement, and loss of hope. We know that those things are very common among people with chronic medical illness and among many of the patients that we take care of and we see. It's a real struggle to be sick and disabled, to have to deal with chronic pain or, have one's life threatened by an illness that could change one's life, make it so that one can't work, make one a burden on one's family. This creates a lot of distress. And for many people, they deal with that stress through their religious faith. Now I'm going to review a little bit about whether or not those who depend on their religious faith to cope, for example, whether they're any healthier. Does it do any good? Does relying on a person's religious faith, being involved in religious activities, does that actually help them feel better mentally and physically? So let's go into some of that research now. So let's look at mental health first of all. Depression. Depression is the most common emotional disorder found in medical settings. And some of the studies that have been done indicate that close to 40 to 50% of medically ill patients, particularly those who are admitted to the hospital, suffer from a depressive disorder of some kind. Now, as far as the research with regard to religious involvement is concerned, there have been 444 studies that have looked at this correlation between religious involvement and depression. And of those studies, over 60% find that those who are more religious experience less depression, recover more quickly from depression, and respond more quickly to a religious or spiritual intervention. And if you look at the higher quality studies, the percentage of those studies that show this connection with less depression is even greater. Now, a small number of studies do show that those who are more religious are actually more depressed than those who are less religious. Those studies are primarily, though, in people with severe chronic illness, people who have turned to religion to cope with the stress and the depression they're experiencing. So in some populations, religious coping can actually be a marker for the person going through a lot of stress or dealing with more depression. And we think that those positive associations in those studies are due to that. Now, there has been a study published in early 2014 in JAMA Psychiatry. And given that this is a this area of neurosciences has become very, very important in medicine and in the study of religion, this particular study is very important. So this was about the neuroanatomical correlates of religiosity and spirituality. So in this particular study, they looked at the brains. This is Columbia University. These are researchers well known in the psychiatric world who have done a lot of psychiatric epidemiology, but they've been following these patients who have major depression and then following their children and their grandchildren. So they're actually looking at the transmission of depression across different generations. Now, this research group has also looked at the importance of religion or spirituality in the patient's life and has tried to figure out how that may influence the transmission of depression across generations. Now, if you look on the slide here that I'm presenting, you'll notice that there are two sets of slides, or two panels here. The one on the left shows the brains of individuals at high risk for depression for whom religion was not very important. On the right-hand side, though, are the brains of people who indicated that religion was very important to them. Now, all of these individuals are at high risk for major depression because their parents had major depression or their grandparents had it. But if you look at those slides on the right panel, you notice that there's a lot less red areas on the right-hand side. Those red areas indicate actual shrinkage of the cerebral cortex, which seems to be a result of experiencing long periods of depression or being at risk for a depressive disorder. To have these widespread areas of the cerebral cortex, and actually even the inner parts, the inner parts of the brain seem to have shrunken because of the effects, of maybe depression or of the risk factors involved in depression. But among those for whom religion is very important, notice that those brain areas are not as shrunk. So it seems as though religious involvement may in fact, you may in fact actually be able to show it in the brain, that religious involvement may protect the brain from the shrinkage that would naturally occur among those who are not religious. This may have something to do with the ability that religion has to help people to cope better with their circumstances and even their depression. Now, emotional disorder, particularly depression, seems to be different among those who are deeply religious. Now, everybody gets depressed, those who are religious and those who are not religious. It does seem as though those who are religious are less likely to develop depression, but that doesn't mean that they don't get depressed. So we did a study looking at patients with major depression, and we looked at their religiosity, and this was a cross-sectional study. It was actually the baseline evaluation of a study that looked at a religious intervention to treat depression in those with chronic medical illness. But this is the baseline evaluation before the intervention was implemented. What we looked at is we looked at the relationship between participants' religiosity and their positive emotions. Now, bear in mind that all of the patients in this study have major depressive disorder, because that was one of the inclusion criterion, because this is a treatment study for major depression. But we're looking now just at the baseline evaluation, in which we measured the severity of depression and measured the positive emotions that individual experienced. This included things like their sense of meaning and purpose in life, their optimism and hope, their sense of gratitude and thankfulness for what they did have in their life, and their sense of generosity towards others. So the slide I'm going to show you next has the level of religiosity on the x-axis and the positive emotions on the y-axis. And you can see that as people become more religious, the low religious are in the first quintile, and then the high religious are in the fifth quintile. If you look at depressive symptoms, which are on the right y-axis, which says Beck Depression Inventory, you notice that the level of positive emotion of depressive symptoms, that lower line, is pretty much steady, or it's the same across all levels of religiosity. However, if you look at the upper line, notice that positive emotions are increasing significantly depending on how deeply religious the person is, even though their depression doesn't seem to be any different. Now, again, this is a cross-sectional study, and everybody has major depression. So therefore, we wouldn't expect really to have any difference in depressive symptoms. But the fact that there's an increasing level of positive emotions among those who are more religious is very significant. And of course, these findings were highly significant and published in the Journal of of psychosomatic research last year. Okay, consequently, it wouldn't be surprising then that suicide is a lot less prevalent among those who are more religious. There have been actually 141 studies that have looked at this relationship, and of those studies, 75% indicate that people who are more religious just don't commit suicide as often. They don't attempt suicide. They basically have more negative attitudes towards suicide. And that makes a big difference. So from a psychiatric standpoint, as a psychiatrist, if I find that a patient is religious and is part of a faith community, I'm a lot less worried that they're going to commit suicide. Just because those individuals who are more religious, they have more purpose and meaning in their life. They have less reason to commit suicide. And they also have the strong religious prohibitions against committing suicide, which really make a difference as well. Let's talk a little bit about well-being and happiness. Religious involvement is related to greater well-being and happiness in 80% of the research out there. And there's been a lot of research. Over 300 studies have looked at this quantitatively. And of those, 80% find that religious people are just happier. They just experience fuller, more vibrant, greater well-being in their lives when everything else is equal. So this is a lot of research. Less than 1% of those studies indicate that religious people have lower levels of well-being or less happiness. Here's a slide looking at religion and well-being in later life. This was one of my first studies I did probably 25 years ago. We had a bunch of older adults, about 800 or so, and we looked at their level of well-being using an established scale and looked at their level of religious attendance and their level of intrinsic religiosity. As you can see, as church attendance increases or as intrinsic religiosity increases, well-being increases in almost a stepwise fashion. Now, not only is religious involvement related to greater well-being, it's also related to more meaning and purpose in life. So more than 90% of studies indicate that those individuals who are religious have more meaning and purpose in life. They have more hope in the vast majority of studies. They're more optimistic in more than 80% of the studies. And being more hopeful, more optimistic is going to have consequences in terms of the patient's motivation to take care of themselves and their recovery from medical illness. As you all know, people who suffer serious medical problems or have surgery for a hip fracture or, have a stroke or have a heart attack, there's a lot of effort necessary to rehabilitate from these illnesses, and being more hopeful, more optimistic, people are just going to make more effort. They're going to be able to make more effort in their self-care and in their rehabilitation and in their recovery, and that's going to make a difference. Alcohol use, abuse, and dependence. That's a real problem. That's a real problem. Many people, their lives are shortened and terribly damaged by becoming addicted to alcohol or drugs. And religion can really make a difference in terms of preventing the development of addictions and helping people to recover from alcohol abuse and drug use. If you notice here, there have been 278 studies published in the peer-reviewed literature prior to 2010. So these are all studies that, all of them that I'm citing here in this review now are those studies published prior to 2010. And of those 278 studies that were looking at substance abuse and use, 86% find that those who are more religious just aren't using drugs and alcohol as much. And this is especially among young people. This is young people in high school and college. If they're religious, they're just less likely to use alcohol and drugs in 90% of this research. And these are big, large studies that have prospectively followed young people, thousands of young people, random samples for decades. And these studies suggest that, religion can be real preventative in terms of drug use and alcohol use and abuse. Social health. We'll talk a little bit about that now. Social support is much higher among those who are more religious. Those who are more religious say that they have more friends, they have more social contacts, they talk to people more often, and they feel more supported, when they go through stress or when they have physical health problems. So religion can make a real difference in that regard, especially being involved in a faith community. Do you know of all of the predictors, the strongest predictors of health with regard to religious beliefs and practices? Some of you may be wondering, what is it about religion? Well, the strongest predictor is involvement in a religious community. In other words, attending religious services and really getting involved in the faith community. That is a very powerful predictor of mental, physical, social, and behavioral health. So with regard to studies looking at social support, there have been 74 studies. Again, over 80% find that religious people just experience greater social support. Delinquency and crime is another factor. There have been 104 quantitative studies looking at this connection between religion and delinquency and crime. Of those studies, again, close to 80% report an inverse relationship between spiritual or religious involvement and delinquency or crime. Religious involvement among youth is also associated with better academic performance. So they do better in school, religious youth. They're more likely to graduate from high school, to go to college, and to do well. So, of the studies that have looked at this, 11 out of 11 report this. Again, these are peer-reviewed studies published in the peer-review academic literature. Also, families tend to be stronger if they have religion integrated within the family unit. Religious involvement is related to greater marital stability when that's been measured, less divorce, greater satisfaction within the marriage, less spousal abuse, and more likely to have an intact family with two parents in the home. That's true for 86% of the 79 studies that have examined this. Let's look at health behaviors. Religious involvement is related to more physical activity. People who are more religious exercise more. They're more involved in activities where they're using their body. Even going to church requires a lot of physical activity. You have to get out of bed in the morning, you have to drive to the church, you have to park the car, go into the church. Sometimes, if you're Catholic, you're kneeling and you're standing and you're doing all sorts of physical activity. And that's good for your health. Also, religious people are less likely to be engaged in unsafe sexual practices. They're less likely to have sex outside of marriage. They're less likely to have multiple sexual partners. And of course, that's going to affect their likelihood of contracting venereal diseases and getting AIDS and all of those terrible illnesses that that ravage our physical health. Also, now with regard to weight, that is one issue that seems to be a real challenge for people who are religious. They tend to be heavier in general. So religious involvement is related to greater weight, and those who are less religious tend to be lighter. That's something, we got to work on. And faith-based interventions within churches to help improve diet and increase exercise and reduce weight have become very popular here in the United States. Next slide, we're going to talk about cigarette smoking. Well, a lot of research has looked at that. 135 quantitative studies looking at thousands of people, following them over time, looking at them cross-sectionally and following them over time. 90% of that research shows that those who are more religious are less likely to smoke cigarettes. And again, this is especially true among young people. And the majority of these findings suggest that religious people just don't start smoking. So these religious youth just don't start the habit. It's not so much that religious people are quitting smoking, although that's true also. The biggest effect is that the religious just don't start. And that can have a big impact on your health if you're not smoking compared to if you're smoking for 30 or 40 years. We all know the effects that cigarettes have on cardiovascular disease, chronic lung disease, and stroke. Okay, here's a slide of a study where we looked at cigarette smoking here in North Carolina. 4,000 older adults were studied, and we looked at how often they smoked, and very clearly those who were attending religious services more often were less likely to smoke. Now let's look at physical health, and that's what a lot of people are really interested in. What effect does religious involvement have on a person's physical health? Let's look at cardiovascular disease. Religious involvement is related to lower blood pressure in the majority of studies. It's related to better cardiovascular functioning as well. People who are more religious tend to develop coronary artery disease more slowly. They're less likely to develop a heart attack and die at a younger age. There have been several major large studies following people for decades, large samples, tens of thousands of adults, where they've looked at religious practices. And they find that those who are more religious just don't have a heart attack as often. And it's been shown in 2/3 of studies that have looked at it. So I think I've got a slide here's a slide looking at diastolic blood pressure. We know that diastolic blood pressure affects risk of stroke and certainly risk of heart attack. But individuals in this particular study, again, this is a large random sample of 3,600 older adults, those who are attending religious services and who are praying and reading religious scriptures, at home in terms of private religious activities, those who are doing both of those, both the religious attendance and the private religious activities, have significantly lower diastolic blood pressure compared to doing those individuals who are doing those activities less often. In fact, the rate of diastolic hypertension among those who are attending religious services weekly and praying or reading religious scriptures daily is 40% less likely. Diastolic hypertension is 40% less likely in those individuals who are doing both those public and private religious activities compared to those who are attending religious services less than once a week and who are praying or reading scriptures less than once a day. Here's a study done out of Israel. This is 10,000 men, middle-aged, who were followed for 25 years. And they looked at, whether or not they died of a heart attack. And what they found was that those who were most Orthodox, which actually meant that they attended synagogue regularly and they prayed in their home, did the Jewish rituals that Jewish people tend to do, and also were sending their children to a Jewish school, which meant, that was a priority to them. Individuals who scored high on that scale of Jewish religious activity were about 20% less likely to die of a heart attack during that 25-year follow-up. Now, what's important in this study is that the findings were independent of the person's blood pressure, diabetes, cholesterol, smoking, weight, and heart disease. So even when they controlled for those factors, still, those who were more religiously active were less likely to die of a heart attack. Now, the next slide looks at immune and endocrine functions. So religious involvement in the vast majority of studies, again, is related to better immune functioning and better endocrine functioning. So basically, cytokine levels, inflammatory markers, are significantly lower among those who are more religious. Endocrine functions, their levels of cortisol, epinephrine and norepinephrine, the stress hormones, are significantly lower among those who are engaged in religious activity. Again, in the vast majority of studies, as you can see from the slide. Again, this is a systematic review. I'm not just cherry picking or selecting studies that are, favorable towards the hypothesis that religion is good for your health. The fact is that religion is good for your health. And however you measure it, it seems to indicate that religious people are healthier. Now here's a study where this is one of the first studies looking at immune functioning biomarker levels, cytokine levels in those who are religious versus less religious, looking at religious attendance. Serum IL-6 is a cytokine. It's an inflammatory marker. It tends to increase in the bloodstream of people whose immune functioning is getting weaker. For example, older adults have higher levels of inflammatory markers like IL-6. Patients who have AIDS or who are HIV positive have higher levels of IL-6 and other indicators of inflammation. Again, it's an indicator of a weakened immune system. However, our study was able to show that people who attended religious services more often, that they had significantly lower levels of IL-6, suggesting that their immune systems were stronger and functioning at a more healthy level. Now, one of the best markers for the lifelong effects of a behavior or an attitude or a belief is mortality, because mortality, length of life, is kind of a cumulative indicator of the effects that a behavior like religious involvement might have on a person's health. And you can see from this slide that I have up now, there have been 120 studies looking at the relationship between religiosity and longevity. All of these studies are prospective cohort studies that involve thousands of people followed for up to 70 years, actually. There have actually been some studies that have followed people from their teenage years all the way into their 80s. And the findings from these studies overall indicate that close to 70% indicate that religious people live longer. And if you look at the best studies, the highest quality studies, you actually find that 3/4 of those studies indicate that religious people live significantly longer. The difference in longevity is somewhere around 7 years, about 7 additional years of life among those who are more actively involved in religious activities. And that's true for white individuals, for Caucasians. For African Americans, for Black Americans, the difference is closer to 14 years. So you can see that religion, particularly in the minority communities, has an enormous effect on a person's health and their longevity. Here's a study looking at mortality after open heart surgery. And this was a study out of Dartmouth Medical Center up in New Hampshire, the northeastern United States. They followed older adults after open heart surgery for a period of 6 months. What they found was that individuals for whom religion was important to them in coping and who were involved in social activities, which were a lot of times religious in nature, that those individuals were much less likely to die compared to individuals for whom religion wasn't important and who weren't involved in any type of, social activity. You can see here from this slide that the mortality rate is actually 14 times greater among those without that religion and social support compared to those who had that kind of support. And that's after controlling for the biological predictors of mortality during that follow-up period. Here's a study now looking at church attendance and longevity. This was one of our studies of 4,000 older adults who we followed for 6 years. You can see the survival curves for those who attended religious services at least once a week or more compared to those who attended less than once a week. They're really pretty significantly different. The difference there is 28% in terms of likelihood of survival, and that's after controlling for baseline physical health and all sorts of different social and psychological measures. Now, if you want to get one picture of what is the association between religion and health. And you want to put it all on one slide, and you want to, look at all of the studies that were done prior to the year 2000, looking at these connections between religion and health. Here is the slide. I want to show it to you. You can see here that on the y-axis, you've got the number of studies. You can see it goes up from 0 up to 2,500 studies. Then on the x-axis, you've got various findings. Let me explain. C at the bottom there means that the findings were complex. In other words, you read the study and it was so poorly described, you actually couldn't figure out what they found. So we put those studies in the category called complex studies. There are about 25 of those. Now, there were 250 studies that found that religious involvement was related to worse health. Now, as I say health here, I'm talking about mental, social, and physical health. So 250 studies have been reported and published in peer-reviewed literature that indicate that those who were more religious were actually sicker. They had worse social health, they had more depression, or worse physical illness. Again, as I said before, a lot of those studies were cross-sectional, and sometimes when people get sick and chronically ill, they turn to religion, and that produces this artificial positive correlation between religion and poor health. There were a number of studies, not too many of them, that showed a trend in that direction. There were, 250 studies that showed significant positive and negative relationships with health, depending on the religious characteristic that was measured. There were about 100 studies that found that those who were more religious tended to have better health, but it wasn't statistically significant. Now, the next column are the percentage of, or actually the number of studies showing that those who were more religious had significantly better mental health, physical health, social health, or better behavioral health. So you can see that there are a whole lot more studies, close to 2,400 studies showing a significant relationship between religious involvement in health. And these studies are from all over the world. So it's not just the United States. And then there are a number of studies that find no association between religion and health. Bear in mind that these are all the studies out there, both the ones that found an association and ones that didn't, because this is a systematic review of all of the literature. Okay, so let's talk a little bit about the latest research from Duke. We just completed a study of 132 people with major depressive disorder that were randomized either to religious or to conventional or secular cognitive behavioral therapy. Now, we had half of the sample was from Durham, North Carolina, and half of the sample was from Los Angeles County in California. And all of these individuals received 10 50-minute psychotherapy sessions that involved either religious psychotherapy or secular psychotherapy, which avoided the talking about religion. So basically, this was a randomized clinical trial. It was a large study, pretty large. It was cost over $1.3 million, and we published a lot of papers out of this study, and I want to show you the results. We actually delivered religious cognitive therapy in 5 different versions. We have a Christian version, we had a Jewish version, a Buddhist, a Muslim, and a Hindu version. We wanted to provide the religious cognitive therapy in the religious tradition of the patient. Now, we actually have the workbooks and the manuals that describe exactly how we did this intervention up on our website, and that's displayed up there on the screen. That's our website address. And there's a tab up there that says Religious CBT. Just go to that, and that will give you all of the studies that report the results from this research and also the manuals that show you how to actually conduct the research. Here was kind of this next slide shows you a kind of a visual description of how the study was done. You can see that on the left-hand side, you've got the religious cognitive behavioral therapy, and the conventional cognitive therapy, and we're comparing those two. In the religious cognitive therapy, we're using the person's religious beliefs and practices to increase their gratitude, their altruism, their generosity, to help them make sense of their medical illness, and to help them cope with their depression. In the conventional cognitive behavioral therapy, they used secular methods of increasing gratefulness and altruism and generosity, and they focused on dysfunctional cognitions and behaviors, and various secular methods of trying to alter those dysfunctional cognitions. Whereas in our religious CBT group, we used the person's religious beliefs to challenge their negative thinking related to their illness, and trying to give them more hope and optimism, and increase their social support. Again, really the only difference between these two interventions was that one of the interventions used the religious resources of the patient to alter their depressive symptoms, whereas the other intervention used secular methods of altering the dysfunctional cognitions. Now, the only challenge in this particular study was that the people, the therapists who delivered the religious cognitive therapy, had a lot more to fit into their 50-minute session than did the people who were delivering just the cognitive therapy. And because, the religious therapist had to incorporate religious beliefs into the therapy, which added about 20 to 25% more time. So they were kind of rushed in delivering the religious CBT because they were all being videotaped, audio taped, and they were being rated on whether or not they followed the protocol. So the religious therapist had a little bit less time to spend developing the relationship with the patient because they had to cover all of the extra material, in the manual. So in any case, that was the study, and then we looked at the outcome. The next slide shows the results. So the religious and the conventional therapy both reduced depressive symptoms during the 12-week treatment protocol and the 12 weeks after the treatment ended. And they were about equal. The religious CBT group, the ones that got the religious CBT, did a little better, but it wasn't statistically significant. But there was some significant findings, and that was that among those who were more religious, the religious CBT actually did significantly better than the conventional CBT. So for those who were very religious, the religious therapy worked better. Also, those individuals were more compliant with the religious CBT than with the conventional CBT because, it reinforced their existing religious beliefs. So, for a long time, mental health professionals have said that if you bring up religion in therapy sessions, it's going to make the person worse. And that's just not true. That's not true based on this randomized clinical trial. And if anything, among those who are more religious, the religious CBT works significantly better. Here's some more of the findings of our study. We actually did the genotype. We got genotypes on all of the participants to identify genetic polymorphisms. And we wanted to see whether there was a certain genotype in which the religious CBT worked better. And in fact, we found one. It was actually the genotype C/C of the serotonin receptor gene. So there's a gene that codes for the serotonin receptor in the brain. And this particular gene, if they had the genotype C/C, then in that group, the religious CBT was significantly better. Okay, next slide. We also looked at optimism as an outcome of the religious versus the conventional CBT. And as you can see from this slide, those who received the religious CBT did significantly better immediately after the 12 weeks of therapy were completed compared to the conventional cognitive therapy group. Now, religious CBT also seemed to decrease urinary epinephrine levels significantly faster among those, getting the religious CBT in this group compared to those getting the conventional group. You can see that from the slide. Those, with the red, in the red is the religious CBT, and that those levels of urinary epinephrine are going down significantly faster, or close to significant. The p-value is 0.06 in the religious CBT group compared to the conventional group. We're also doing a study of caregivers. These are caregivers of people with severe dementia or with neurological conditions. We know that there's a lot of stress in caring for a loved one, a family member with dementia or stroke or some kind of bad neurological disease like Parkinson's disease. And we wanted to see whether or not religion made a difference in terms of the caregiver's ability to cope with the stress of caregiving, and also the level of the length of the caregiver's telomeres. Now, I'll explain that in a moment, but let's look at the coping with stress. What we found was that the caregivers who were more religious were able to cope better and adapt better to the caregiver role. That's exactly what we thought we'd find, and that's what we found. It's consistent with all of the existing literature. As you can see from this graph here, on the y-axis, the caregiver adaptation, the higher the score, the worse the adaptation, okay? And the lower the score, the better the adaptation. So you can see that among those who have low religiosity, those who are in the 0 and 1 level there on the x-axis, that their level of caregiver adaptation is actually a lot worse. And that as religiosity increases, level of caregiver adaptation significantly improves. That study is coming out in January of 2016 in the American Journal of the Journal of the American Geriatric Society. Now, here's what I'm talking about with regard to telomeres. So you can see there that the telomere is the very end of the chromosome, very end. And with each replication of the cell, the telomere shortens. And when the telomere gets to a certain level, the cell dies because it can't replicate anymore. So telomere shortening, the length of the telomere has been, been found now to be an indicator of aging. And it's a biological clock within the cell that people are using to actually predict lifespan. Because people with a short telomere have a shorter lifespan, and those with the longer telomere are going to live longer because, their telomere is longer, and, their cell is going to be able to continue to divide over time. So in any case, we want to see whether or not maybe those who are more religious have actually longer telomeres, and this might help explain why religious people actually live longer. Now, in our particular study, we did find that telomere length went down with increasing age. You can see that from the slide that I'm showing here. So the lab that measured the telomeres was actually the lab of the person who got the Nobel Prize in 2008 for the discovery of the telomere and of the enzyme that actually lengthens the actual telomeres. Barbara Blackburn's lab at the University of California, San Francisco. So in any case, our study was able to show that as people grew older, as they aged, that their telomeres significantly shortened. Now, unfortunately, we have the study now in submission looking at religious involvement and telomere length, and so you'll have to wait until that study comes out in the journals. Now, we have a number of other studies we're doing at Duke as well. We're looking at spiritually oriented cognitive processing therapy for the treatment of moral injury in active duty soldiers and veterans with PTSD, post-traumatic stress disorder. We think that moral injury from, killing people and from seeing others killed and their colleagues killed and civilians wounded, we think this moral injury is at the root of PTSD. And if we address moral injury, we think that we can treat the PTSD a lot quicker. You know, right now with secular approaches, only about 20% of soldiers and veterans with PTSD are really getting any better. And we think that if we can address the moral injury through the spiritual resources of the individual, we think that we can increase the speed of remission of PTSD. So that's one of the studies we're doing now. We're doing pilot studies at several VA medical centers and also medical centers at military bases here in the United States, including Fort Bragg and Fort Gordon. I forgot to tell you about our study we're doing in burn patients. We have one of the largest burn units in the United States here in Chapel Hill. And so what we're going to do is look at the effect that religious involvement has on predicting the speed of wound healing in burn patients, and in terms of predicting their speed of recovery, their functional recovery, and going back to work, etc. So that's a prospective study that we're now designing, and hopefully we will be starting that soon as well. So how do you integrate all of this research into the clinical care of patients? There's a big divide here between, the minister and the chaplain and the physician. Most physicians don't address spiritual issues, and of course most chaplains and ministers don't address physical issues. But we think that these areas are complementary. In other words, the physician ought to start addressing spiritual needs of patients to enable them to cope better with their illness and to help them recover more quickly from the condition. We think doctors ought to be addressing these spiritual issues, and we also think that ministers ought to be referring their congregants to doctors if any medical issues come up. So we think that the clergy should be screening for emotional and medical problems and sending them to doctors to help treat them. And we think the doctors ought to be screening for spiritual issues and conflicts, and then getting patients plugged in with a faith community to help address those issues, or at least having a chaplain come by and talk with them about those issues to help them resolve them. So I'm going to talk a little bit about that right now. There are many reasons for doing so, for healthcare professionals, for doctors and nurses, to begin integrating spirituality into patient care. First is that many patients have spiritual needs. They're related to illness, and they affect the patient's satisfaction and healthcare costs, believe it or not. Number two is that religion influences coping with illness and affects the patient's emotional state and their motivation to recover, as I said earlier. Next is that religion affects important health-related behaviors that likely influence medical outcomes. So religion does affect whether or not a person is drinking, smoking, and the capacity that they have to stop drinking and stop smoking. And that's going to affect their health. Religious beliefs also influence medical decision-making, especially towards the end of life. Many patients and family members make medical decisions on whether to agree to a do not resuscitate order, or to withdraw a feeding tube, or to withdraw ventilator support, or whether or not to get chemotherapy. A lot of those decisions are based on religious beliefs, and we've been ignoring that. Doctors have been ignoring that and not discussing that with patients. And consequently, many patients are making decisions about their health care, especially towards the end of life, when healthcare costs are very high based on religious beliefs that they are not discussing with their physician, and their physician is not asking. Also, religious beliefs affect the medical decisions that doctors make. Do you know research has shown, research in the New England Journal of Medicine has shown that doctors who are more religious may not give as much pain medication to patients. And doctors who are not very religious may be more likely to assist in suicide or actually assist in the death of the patient. And many doctors who are more religious are less likely to approve of abortions or to prescribe contraception. So the beliefs of the doctor influences a lot of the medical decisions they're making, but this is never discussed with the patient. This is something that doctors and patients a lot of times won't discuss. There was a recent study just came out in actually, well, it's not even published yet. It's in the later part of 2015. It was a multi-center study of physician family meetings in the ICU. So these were family physician meetings in the ICU to make medical decisions about patients in the ICU that were very, very sick. Of those two, they actually transcribed 250 meetings. And of those 250 meetings, about 15% religious or spiritual issues came up in the conversation. And in only 5% did the doctor raise those religious or spiritual issues. And so that means the doctors are not addressing these issues, even in intensive care units when families are making decisions for patients that are based on their religious beliefs, and it's affecting the cost of health care. Religion also influences compliance with treatment. So those who are more religious are more likely to take their medication. And if a doctor takes a spiritual history, the patient is going to feel that the doctor cares about them more, especially if the patient is religious or spiritual. And that's going to strengthen the doctor-patient relationship and increase compliance. And that has been shown by randomized clinical trials that is indeed the case. So I'm not just making this up or hypothesizing. This has actually been shown. Also, the standards of care in the United States for hospitals require that patients' spiritual and cultural beliefs are respected. And unless you inquire about what those beliefs are, you're not going to be able to respect and honor that person's religious beliefs in their patient care. Okay, here are just some studies. I'm going to go over these quickly because my time is running out, but these are a series of studies at Harvard. You can kind of read these at your own leisure. These are a series of studies documenting that many patients with terminal illness have spiritual needs, and in most cases, no one is addressing those spiritual needs, not the person's faith community or the healthcare system. Now, what the research has shown is that those who are more religious tend to use more health resources in the last week of life, a lot more resources. And the individuals who are religious, who are using those resources, they are not the people whose spiritual needs are being addressed. They are the people who have spiritual needs that are not being addressed by the medical team. That is what these Harvard studies show that have followed patients, hundreds of patients, right up to their death and have measured the healthcare costs. In fact, the latest study that they published in the journal Cancer, based on this cohort of cancer patients, found that the cost among those whose spiritual needs were not being addressed was 2 or 3 times as great in the last week of life compared to those whose spiritual needs were being addressed. So if you look at that slide, that gives you some of the details of that study. So what do you do then? What do you do in terms of addressing spiritual needs? What we are recommending is that physicians should take a spiritual history and talk with patients about these issues. We've developed a 2-minute spiritual history that takes a very short time to administer, and the whole process is less than 1 or 2 minutes. And it makes a real difference in terms of patients' level ability to cope, doctor-patient relationship, and some health outcomes. Next, besides taking the spiritual history, we want the healthcare professional to respect, value, and support the beliefs and practices of the patient. So this is always patient-centered. So it's the patient's beliefs that you want to support. You don't want to necessarily change the patient's beliefs, or you certainly don't want to try to evangelize or make the patient more religious. What you want to do is identify the religious resources of the patient and utilize those resources to then help the patient to cope better and help them to recover more quickly. You want to identify the spiritual needs of patients a little bit. We're asking doctors to take a spiritual history, to talk with patients about these issues, about their spiritual needs. We've got a 2-minute spiritual history. We'd be happy to share with you all that describes how to do that. We also would like the healthcare professional to respect, value, and support the beliefs and practices of the patient. This has to be patient-centered. It can't be a doctor or a nurse trying to evangelize the patient or change the beliefs of the patient. We want to identify those beliefs and support the beliefs that the patient has found useful to them in coping, in particular their religious beliefs. We'd like to identify the spiritual needs that the patient has and ensure that someone meets those needs. Now, the doctor and the nurse, they're not trained to address the spiritual needs of patients, so we'd like to connect patients with spiritual needs to a chaplain or to a clergy person who can address those needs. We also think that it's okay for a doctor or a nurse to pray with the patient if the patient asks. We think the patient should be the first one, though, to ask the healthcare professional to say a prayer. We think that, if the doctor or the nurse asks the patient to pray, that it can be coercive, and we don't want to coerce patients into prayer. We want the patient themselves to want the prayer. Now, sometimes some doctors and nurses have told the patient that they're open to praying with patients, and that should the patient ever want prayer, they would be happy to do that. Now, that's okay. That's okay to inform the patient that the healthcare professional is open to praying with them, but we don't think that it's a good idea for the doctor or nurse to actually directly ask the patient if they want prayer. Now, some clinicians do that. We don't think it's a big deal. We think there's some risk in it because it can be coercive. But if you do it in a gentle way and you kind of take a spiritual history first, that's really important to take a spiritual history first, and then you ask the patient what they would like prayer for, we think that it's okay. We also think that working with the faith community would be a good idea for physicians and healthcare professionals. There's a tremendous complement here, such that medical professionals and health and clergy and religious professionals both have a common aim, and that is the health and well-being of the patient. And we think that if faith communities can interact with healthcare systems to first of all screen for illness within the faith community, connect people to doctors and healthcare providers, and then healthcare providers conducting talks and education sessions in faith communities to inform congregants, people who attend religious services, about health practices. We think that's really good, and we think that healthcare professionals, by taking a spiritual history, can identify spiritual needs that they can then connect the patient with a faith community or with a pastoral counselor or with chaplains who can address those needs. That can make a big difference in terms of the patient's satisfaction and the speed of recovery of the patient from the medical illness. So again, religion and medicine work beautifully when they complement each other. They don't work very well when a person just seeks medical care without taking advantage of their religious resources, or simply seeks religious help or prayer for healing or miracles and doesn't go and see the doctor. We don't think that's a good idea. We think that when the patient both goes to see the doctor, gets the best of medical care, and utilizes their religious resources to help them to cope, to help them to live happier and fuller lives, and to help give their lives meaning, even if they have chronic illness, and aren't getting better, we think that that is the best way for healthcare systems and religious communities to work together to maximize the health of the patient and to minimize the costs of health care. And so, if you're interested in this, I know I've had to be kind of short in terms of describing these applications. I do have a book called Spirituality and Patient Care that summarizes all of the applications. And we have a lot of resources, at Duke that you can access on our website. So in conclusion, religion is commonly used to cope with chronic illness and other medical problems. Religious involvement is associated with greater well-being, less emotional disorder, less substance abuse, more social support, and better health behaviors. Religious involvement is related to less physical illness, better medical outcomes, and greater longevity. And we've got lots of research to back that up. Spiritual needs are widespread in medical settings, especially in those with serious life-threatening disease. We think that assessing and addressing spiritual needs of patients is related to greater patient satisfaction, better quality of life, less depression, lower use of unnecessary health services, better functioning, and a better doctor-patient relationship. And there is research to back up every bit of what I just said. The time to start integrating spirituality into whole person healthcare is now. So I'm hoping that healthcare professionals in the audience will begin looking at how to do this based on your particular setting and your particular culture and the particular kinds of patients that you see. So if you want further resources, here are a couple of slides that provide you with them. Again, as I mentioned earlier, there's Spirituality in Patient Care, 3rd edition. Why, how, what, and why do it, how to do it, when to do it, and what are the consequences of addressing spiritual issues in patient care. If you're interested in the research, the Handbook of Religion and Health by Oxford University Press, 2012, reviews all of that research. I summarize that research in part 1, but some of you might not have had a chance to watch part 1, so you can get all that research right out of the book. And then we have a free monthly e-newsletter. I really would encourage you all to sign up for it. It's free. I write it. I take a couple of days to review all of the research and to summarize it, and to make a comment about it, to comment about how good or how poor it was. And the newsletter has lots of information about other resources. It has information about conferences. It has information about videos, all sorts of good information if you're interested in this area of spirituality and health. Also, here's our website. On the next slide, you can see here that one of the tabs is the religious CBT study. I talked about that in part 1, our randomized clinical trial looking at a religious intervention for depression in the medically ill. And we also are going to have, we do have a tab right now called, that's on CME videos. We have a series of about 5 videos that describe exactly how you integrate spirituality into patient care. And you can also get CME credit, continuing medical education credit, for watching these videos. 3 of them are designed specifically for physicians. 1 of them is designed for nurses, and 1 of them is designed for chaplains. I'd encourage you to watch all 5 of them. They're for free, and they're very highly professionally done. We invested a lot of money to produce these videos, so I would encourage you to go to the website and watch them. Okay, so I think now the last slide is about research. Now, if you want to learn how to do research, come to our research workshop. Many of the people who are presenting actually for these conferences, they have been to our workshop, and we really train people. We've compressed a 2-year postdoctoral research fellowship into 1 week. It's an intensive week. I give a lot of the lectures, but we cover a lot of topics. We talk about the research. We talk about the weaknesses of the research. We talk about the highest priority studies that need to be done. I talk about the different methods of conducting research, how to do statistical analyses, how to write a grant, how to get funding support for research, how to publish a paper, how to respond to reviewers' comments, and how to develop an academic career. We also provide individual mentoring, and there are researchers from Duke, from Johns Hopkins, from Yale University, and from other places that come to talk at this workshop. So it's well worth it. And we also provide scholarships, partial tuition scholarships. If you're at all interested, please send me an email to get more information or go to our website. Okay, so that's the end of part 2. Thank you so much for taking your time to listen, and good luck to you. And I hope that you pursue some of these further resources and learn about the research, conduct the research, and apply the research to clinical practice. Thank you.